know already. Today I'm going to be talking to you about our project, which is on patient-centered surgical care for children in low and lower middle income countries, or LMICs. And this is a scoping review under the supervision of Dr. Panero. So in today's talk, I'm going to be talking you through the background to answer the why, as to why we did this study, talk about our aim. And before we get into sort of the methods and results and our key findings, I want to take a few minutes to actually define some of our key subjects that we're going to be covering in the review. And then I'll go on to discuss our methodology, our findings, and summarize our key results for you. And then I'll talk about our next steps and then open it up to your questions and your feedback. So a little bit about the background into this topic. Patient-centered care and family-centered care as well emerged as a key concept in the late 20th century. And that's really because of an increasing emphasis that was being placed on the importance of meeting the psychosocial and developmental needs of children, but also the crucial role that families have to play in promoting a child's health and well-being. And keeping that in mind, there's been a lot of literature that's been published on patient-centered care approaches, the different domains of patient-centered care, how can we adopt patient-centered care in our daily practice. But a lot of the studies exploring patient-centered care have been disproportionately concentrated in high-income countries. And we actually know that based on a couple of reviews from our lab, which is one of them was on patient experiences, and they found that all the studies that they included on patient experience measures were from high-income countries and predominantly the United States. Another systematic review from this lab again on patient-reported outcomes this time found that less than 10% were from lower middle-income countries, and actually none were from low-income countries. And so keeping that in mind, we really wanted to explore the adoption of key patient-centered care domains in low and lower middle-income countries specifically. And when I say key patient-centered care domains, I want to take some time to actually define what I mean by that. And for the purposes of this study, we define patient-centered care as encompassing these 6 key domains. So that ranges from patient-reported outcomes, experiences, and instruments that measure them, so PROMs and PREMs. Down to patient-parent satisfaction, patient-parent education, informed consent, and shared decision-making. And I'm sure you'll see a recurring theme here is that the parents are also playing a key role here, because especially in the pediatric cohort, a lot of our engagement is with their parents as well. So I'm going to take a second just to define everything for the benefit of the group. So a patient-reported outcome is known as a PRO or a PRO. And a patient-reported outcome measure is what we call a PROM. And a PROM assesses any aspect of a patient's health that stems directly from the patient without interpretation by a physician or anybody else. Standard features of PROMs can be patient symptoms, health status, functional status, quality of life, and health-related quality of life as well. Patient-reported experiences, on the other hand, are a little bit more subjective, and they measure the patient's perceptions of their experience with the healthcare they received as a whole. And PREMs can cover domains like communication with staff, access to information, care received, physical and emotional support, and the consideration of the hospital environment in general. So patient-parent satisfaction. Now, patient satisfaction, or like I said, parent satisfaction in the case of children, is a construct from social research which actually describes the satisfaction of patients with the service that they're receiving. And this is usually defined by a difference between the quality of care they expect versus the quality of care that they receive. And again, this could pertain to specific aspects of care, such as their experience with the staff or their communication, or just pertain to the entire care that they've received as a whole. Patient-parent education. This is mainly an individualized approach, which uses multiple media forms, multiple sessions, different teaching strategies and methods. But the key thing here is it has to impact or affect patients' knowledge, anxiety, and satisfaction, and result in that sort of value exchange here. Informed consent, as I'm sure we're all aware, involves a provider giving general knowledge about the procedure and educating the patient or their proxy about the risks, benefits, alternatives, And there's several methods for providing this information, whether that's verbal or written, and there's different debates as to which is more feasible. And of course, there's also ways of assessing the quality of the informed consent that's being given, such as information recall. And finally, the last or the sixth domain that we're going to be discussing is shared decision making. And shared decision making is an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider all their options and achieve informed preferences. Now, things like decisional regret, decisional conflict, decisional anxiety, and the use of decisional aids are some aspects to be considered under this umbrella of shared decision making. Now, with that in mind, we developed our methodology and researched 7 databases from inception until January this year with no language restrictions. And using variations in text words, we found articles pertaining to predefined domains of patient-centered care. So again, to refresh your memory, that's PROMS, BRENS, patient-parent satisfaction, patient-parent education, informed consent, and shared decision-making. And we were looking at studies specifically from low and lower middle income countries as defined by the World Bank. So our inclusion and exclusion criteria, we ideally wanted a pediatric population, and we set our age limit as 18 years. We looked at all pediatric surgical subspecialties, and I have a little asterisk on that with regards to anesthesia, and that's because while this review wasn't meant to be a comprehensive look into patient-centered care and anesthesia in LMICs, we did find a fair few articles from anesthesia and decided to include them just because of the direct bearing that it has on the preoperative stage of operative care. We looked at LMICs, again, as defined by the World Bank, and looked at studies that were pertaining to patient-centered care in either one or more of the 6 key domains. And studies that described interventions that occurred at any stage, so either preoperative, postoperative, intraoperative, or in a combination of any of these 3. Our exclusion criteria specifically were either a purely adult population or a mixed adult and pediatric population, mainly because we weren't able to distinguish the data when it was a mixed population. Non-surgical specialties like medicine, psychiatry, other community specialties, studies that were not from LMICs or were in a mixed high and low income setting, because again, we weren't able to distinguish the data in most of these studies. Studies that were not patient-centered according to our 6 domains, or studies where patient-centered care was not the primary focus. So quite often we saw that patient satisfaction, for example, was mentioned, but this was just a sentence or 2 in their results, and we decided to exclude these studies. Letters, editorials, opinion pieces were also excluded, as were reviews, but again, some asterisks around reviews because studies that were included in the reviews were independently assessed for inclusion criteria. So study selection, now this was again a fairly standard process. We had 2 reviewers, myself and my colleague Kaisalia, doing title and abstract screening on Rayon, and this occurred between February and March of this year. We resolved all our conflicts by discussion and arriving at consensus, and then we carried out the full text screening on Microsoft Excel between March and April, and we had a 3rd independent reviewer, Dr. Panera, adjudicate for any conflicts that arose at this stage. We extracted all our data and analyzed it on Microsoft Excel as well. We extracted data such as study characteristics, so things pertaining to like study design, the country where it was published, study setting, whether it was urban or rural, participant characteristics, so the sample size, the ages of the participants, the key population that was being studied, so whether that was the parents or the children themselves, and also the patient-centered care domains. So what was the total number of domains studied? What were the tools they used? Were they validated or unvalidated? And what were the key results of each study as well? So that brings me to the first slide of our results, where we're going to talk about this Prisma flow diagram. So as I mentioned earlier, we identified records from 7 databases. And before screening, we excluded 938 duplicates, which left us with 8,050 titles and abstracts to screen on Rayon. Following this, we had excluded 7,819, and that means we were left with about 231 going into the full text stage. We were unable to retrieve 11 of these full text, given that they were conference abstracts or just not being able to be found by the library because they were too old. And that left us with a final 220 full texts, of which we excluded 184 for a variety of reasons that you can see on your screen. most commonly because they were not in LMICs. Quite often the abstracts didn't give us the information as to which country where the studies were carried out, and so finally in the full text data we were able to exclude those. And that left us with 49 studies that we included, 47 from the original 220, and 2 from a systematic review where the review was excluded itself, but 2 studies were included from the studies that they included. So of these 49 studies that were finally included, most of them were cross-sectional in their design at 40.8%. Most of them were single center studies at nearly 90%, and most of them were performed in an urban setting. Some you can see were also performed in both settings, and some very few in rural, and we just didn't have some details as to where they were performed for about 3 studies. And regarding what they focused on, most studies were in the post-operative stage. And we also had a few studies actually that intervened at the preoperative and the postoperative stage and tried to measure a difference with the same cohort. And as can be expected, there was no studies pertaining to the intraoperative stage. And as far as subspecialties are concerned, again, not surprisingly, general surgery was the most commonly represented, followed by ENT and plastic surgery. And there was a few studies that also represented multiple specialties. And these were studies mainly looking at, say, for example, daycare surgery, where there were several specialties represented, several different types of operations taking place. So now I want to take a moment to discuss really the geographical distribution, because this, I think, is a key result from our study. And as you can see, the bulk of the studies actually came from India, very closely followed by Iran. Which is why the Southeast Asia region and the Eastern Mediterranean region have quite a large dominance when we divide it based on the WHO regions. What you will also notice is we had just 1 study from the America region, which is the 1 study on the left from Honduras, and quite a decent representation from the Africa region as well. Importantly, however, most of these studies were from lower middle income countries, and very, very few were from low income countries. And while we're talking about sort of geographical distribution, I want to take a second just to talk about the authorship equity as well, because that's becoming quite a hotly debated topic in the field of global surgery. And so it's important to consider where were the authors for all these studies from. And we found that 24.5, or nearly a fourth of authors, lacked LMIC affiliations entirely, and 17.4% of senior authors lacked LMIC affiliations. And when we divided this down by region, we noticed quite some interesting results. So with first and last author pairs, studies from Southeast Asia and Eastern Mediterranean regions actually had the most first and last author pairs purely from LMICs, at 82.4% and 88.2% respectively. And this is by and large mostly due to the bulk of the studies being from India and Iran, where they did pretty well to achieve authorship equity with their first and last authors. And again, in this table, it looks as though the America region did extremely poorly at 100% of first and last author pairs belonging to high-income countries, but we have to remember, again, there was just 1 study from that region. But both first and last authors were from a high-income country. So now some of our key results. Now the mean sample size was 113 plus minus 166 as the standard deviation, which does mean that it was quite widely spread. The median sample size was 80. Most respondents were parents. Now I would like you guys to keep this in mind, and I'll discuss this a little bit more in a few slides. The mean age of the parents, where it was given, just in about 9 studies, was 34.29, and the range was 18 to 58 years old. And the mean ages of the children was 7.4 years old, ranging from a day to 18 years. And overall, we had a lot more data reported about the children than the parents. As you can see, just 9 studies mentioned the parents' ages, and just 20 studies mentioned the sex distribution. And now talking about the sex distribution, there were nearly 4 times as many female parents as male parents in all these studies. And the children that were being studied were mostly male. outweighing female children nearly again twofold. So the 40 studies that discussed the parents' perspective, I quite like the Venn diagram here because to me, I think it really clears up what we're looking at. I think it's important to know that parents made up a bulk of the respondents here. And especially I wanted to point out that there were only 14 studies of 49 that actually considered the child's perspective directly. And of that, only 5 that focused just on the child's perspective. I think it's also important to note here that there were 2 studies that focused entirely on the perspectives of others. And others here include independent observers, nurses, surgeons, or lay assessors. So the intersectionality of all these perspectives, the others, the parents, the children, is actually quite important to observe, especially with the fact that parents form the bulk of it. Just 5 studies looked at just the perspective of the child, and there were actually 2 studies that looked just at perspectives of others. So there was a median of 1 domain discussed in each study, ranging from anywhere between 1 to 3. And the 6 key patient-centered care domains were discussed a total of 70 times across these 49 studies. And I just want to clarify something about the methodology here, just to make that clear. There was quite a few studies that discussed more than 1 subdomain of each domain. So, for example, there were several studies that discussed, say, post-op, patient-reported post-op pain, as well as patient-reported post-op quality of life, for example. And both these subdomains fall under the domain of PROMS. And so PROMS as a domain was just counted once in these studies. So yeah, just wanted to clarify that. And as you'll see, PREMS was the most commonly studied patient-centered care domain, followed by patient-parent satisfaction and patient-reported outcomes. And informed consent and shared decision-making made up the least studied patient-centered care domains in LMICs. I'm now going to go into a bit of a deep dive into what were the subdomains discussed and what were the tools they used and what that really looks like. So starting with the most discussed, which is PREMS, you can see a real variety of subdomains that were discussed under this domain. And that ranges from the parent experience of care, the patient experience of care, ideas, concerns, expectations, anxiety, all the way down to preferences and care burden. What you will notice is that patient pre-op anxiety was the most commonly studied. And what I want to point out with these 2 graphs is you can follow the lines to see the validity or lack thereof of the tools that were used. So the validated studies are in light green, and the unvalidated tools, are in dark green. So you'll notice that there's a fair split here. Patient pre-op anxiety had the most number of validated tools used, and things like patient pre-op information needs, parent awareness and knowledge, experience of care, ideas, concerns, expectations, some of the more vague, open-ended ones lacked validated tools. And then talking about PROMS, health-related quality of life was by far the most mentioned, followed very closely by post-operative pain and post-operative outcomes in general. And then you'll see on the right, quality of life and health-related quality of life, post-op pain, actually had several validated tools being used. And again, the reason that the numbers don't necessarily correlate is because some studies studied quality of life, but used multiple tools in their studies to study the same subdomain, which is why there's more tools than subdomains. But again, like you see, things that are more quantitative, more easily available, have been around for longer, have more validated tools available for them to be studied. In talking about patient-parent satisfaction specifically, we talked about parent satisfaction with daycare surgery, parent satisfaction with the anesthesia care they received, parent satisfaction with the care they received in general, and their satisfaction with post-operative outcomes. Only 2 studies actually discussed patient satisfaction, and both the studies pertain to post-operative outcomes. And again, you can see there's more unvalidated tools being used as the subdomain becomes a little bit more and more subjective. So now talking about patient and parent education. There were 4 studies that talked about patient-parent education, 2 talking about parent education about the condition or the procedure itself, and 2 talking about parent education on discharge. And both these studies included unvalidated methods or tools. Regarding informed consent, we had 2 studies and they both talked about informed consent pre-op. Nothing specific, nothing too special, and both were unvalidated methods as well. And finally, shared decision-making. The only study in LMICs that discussed shared decision-making was a study on decisional regret, and they used a validated measure known as the decisional regret scale to carry out their study. So just to summarize, PROMs and FREMS were by far the most used, most studied patient-centered care domains in low and middle-income countries. Informed consent and shared decision-making were on the other spectrum, where they really need greater adoption in LMICs. And across the board, validated tools are lacking across most of the domains for patient-centered care. And voices of children and young people are rarely heard themselves in their care, and therefore must be prioritized going forward. Authorship equity still eludes most countries and regions, and low-income countries in particular must integrate patient-centered care approaches into their health systems. And I say the last point with a little bit, with a grain of salt, knowing that there's an abundance of reasons as to why this is not occurring at this stage. And just to take a second to acknowledge the fact that even though it's possible that patient-centered care approaches might be being adopted in low-income countries, we don't hear about it due to things like authorship equity and access to academia and global surgery. So yeah, with that, I will go on to our next steps, which is a risk of bias assessment, which I'm aware is going to be crucial for the publication of this, and we're planning to work on that this week. I'm very grateful for this opportunity to get all of your feedback and questions and help me think about these results a little bit more. And the rest of the time will be focused on our manuscript writing. And thank you guys for listening to me. And I'll stop here for any questions, and my contact details are up on the screen as well.